Good evening, and thanks for joining the UVM Health Network presentation of No Crystal Ball, Advanced Care Planning in Uncertain Times. I'm Christine Buck, and I'm the Community Health Resource Center Program Coordinator at UVM Medical Center, and I also manage the Health Source Classes series. It's been an historic and challenging year due to the COVID-19 pandemic, and our new ways of working and meeting have changed our class programming. This is why we are now offering our free classes online, and we can now also welcome participants from throughout our entire UVM Health Network region of Northern New York and Vermont. And we hope that you'll enjoy this new virtual format. Before we get started, I wanted to review a few important housekeeping items. This session is going to be recorded and all attendees are muted. If you want to engage with our presenters, please use the question and answer box. It may be on the right-hand side of your screen toward the top or down below, and it looks like a couple of flags with a question mark. And we'll try to answer as many questions as we can during the presentation and toward the end. If we're unable to answer your question during the presentation, we will follow up with you by email later. We'll also be sending you a survey and the class slides, resources, and also a recording once we have that within a couple of days. So please keep your eyes open for that. So tonight we are joined by two of our experts, Cindy Pruzese and Sally Bliss. Cindy is the Executive Director of Vermont Ethics Network and also a clinical ethicist. And she's also a clinical ethicist at the UVM Medical Center. And then Sally is a clinical ethicist at UVM Medical Center and also an adjunct assistant professor with the Larner College of Medicine. So I'd now like to welcome Sally and Cindy.
Hi, everyone. I'm assuming you can hear me, hopefully. So thank you very much, Christine, for the introductions. As Christine said, I'm Cindy Pruzese. I'm the director and the clinical ethicist at the Vermont Ethics Network. I've been there since 2008, so heading on into my 13th year here pretty soon. And we spend much of our time doing this kind of work across the state, helping people navigate advanced care planning and medical decision making, hopefully in advance of a health crisis happening. And I also work with healthcare facilities across the state in my role at the Ethics Network, helping them to navigate difficult questions that arise in the course of providing good care for patients and families. So I'll give Sally a
Hello, folks. Good evening. I hope you can hear me, and I'm glad to be with you this evening. My name is Sally Bliss, and I am a nurse. I've been a nurse for a long time, about 35 years now. My background is in surgical intensive care, burn shock trauma, and housewide clinical supervision. And it was through all the years of serving in these bedside roles that I really came to have firsthand experience of navigating the very difficult questions and situations that present when you are faced with a health crisis and difficult decision making, and really beyond that, policy decisions and beyond, and how to help people have a better understanding of the situation at hand and the decisions before them. That is what interested me the most, is trying to help people in these very critical moments, and that is what directed me towards my present day role, which is as a clinical ethicist. And I love my work. I still do basically the same work that I did as a bedside nurse and critical care nurse for all those years. I just wear a little different hat. I'm very pleased to be with you this evening, and I look forward to our conversation.
Okay. So Christine, do you want to move to the next slide for us? This is just a quick overview of what our goal is for all of you today, what we're going to talk about. making and planning and hopefully documenting healthcare decisions in advance. I'm going to talk a bit about the tools in the whole advanced care planning process. Those documents we call advanced directives, and we'll clarify this terminology: advanced directives, living will, powers of attorney. We'll have a little discussion about that. Talk about DNR, COLST orders. These are different types of documents that can be completed in advance, the guide medical decision making, and a little bit also about the Vermont Advanced Directive Registry. And then we were hoping to turn our attention a little bit to maybe some disease-specific considerations. We're in this time of COVID-19, and that certainly has prompted a lot of people to think a little bit more about what their values and priorities are when it comes to healthcare, particularly if something unexpected like COVID were to happen. And how do we make sure that the care and treatment that is available is in alignment with the care and treatment that you want? And so we'll have some discussions about that, as well as maybe other types of diseases that may be on people's minds. There is, as Christine mentioned, there's the ability for you all to publish questions that you may have over on the Q&A section of the screen. So where you see those little icons that look like bubbles with a question mark in the middle, if you click on that, a little menu will pop up on for me, it's on the right-hand side of my screen. And I'm already seeing that someone has asked a question about, is one-to-one guidance available to help people work through their advanced directives? This is available, and on the Vermont Ethics Network website, we do have a link where you can contact people in your area that may be able to help you. You can certainly call our office at the Vermont Ethics Network and we can guide you. So feel free to, we have our contact information. Christine will send that out also at the end of the presentation. And then feel free to contact our office at any time. So from here, I'm going to turn it over to Sally so that she can give us an overview of the advanced care planning process.
Terrific, thank you. I will just add to Cindy's list of people who can help people with one-on-one guidance. There are folks that are located within the primary offices, primary care offices throughout the network that can help you in the primary care office, who can sit down with you and talk about the advanced directive care planning process. But also, I would ask that you talk to your provider, talk to your primary care person. Especially if you have some concerns, health concerns, a chronic health concern, or a new diagnosis, and you're wondering how you might need to think about that or want to think about that. Those are the people that can really help you frame it with whatever it is that you're struggling with your health, and they can help you to frame some important priorities for you. So there's another opportunity and another resource for you. Christine, if we could have the next slide, please. Please and thank you. So I'm going to give it just a couple seconds here because there is a bit of a delay. And this slide here is to talk about the advanced care planning continuum. And so it kind of segues nicely with what I just said. Should you have a new diagnosis or are just beginning your advanced care planning journey, you begin at the top and you begin with probably the most important thing you can do ever, regardless of your health status, is to name a healthcare agent. This is the first step in the continuum of healthcare planning. This is a lifelong activity. This is an important step for everyone, and I mean everyone as of the age of 18. Illness and injury happen to people at any time, young healthies to older folks as well. Trauma and tragedy can hit anyone at any age, and it is especially important, the most important thing, I cannot stress it enough to you, to name a healthcare agent. And if you do nothing else but name your agent, you're already heads and shoulders above where you need to be, because having someone who knows you well, who can speak for you when you can't speak for yourself, is the most important thing you can do. So naming a healthcare agent, we're going to talk about how to do that later in the presentation, but naming that agent is a fairly simple thing to do. We're going to go over the form later on. It's a one-page form and a very easy thing to take care of. That is your first step, and generally that is for everyone to include the younger, healthier folks as of age 18. And typically we ask that you revisit that to be sure that your agent not only knows you well, but can also be available to guide the healthcare team and is traveling along your health journey throughout your life with you and knows of your current circumstances and how you might look at your healthcare decisions as you move through life. The second step along this path is to think about completing an advance directive with some details about your preferences. I think typically people will think about the details of an advance directive in a very specific way. In other words, they may think very specifically about medical technologies like a ventilator, which is a breathing machine, or a feeding tube, or dialysis. And while it's important to think about those things in general, they're very weedy things. They are very complex technologies to apply, and it's never just a ventilator. It's a package of things that come along with the ventilator that becomes very tangled. And so when you get to a point where you are starting to think about an advance directive along with some preferences, I would recommend that you think about these things very broadly and start to think about what priorities you have, what sorts of activities give you meaning, what are the important things for you to be able to do, not only act out, but think out. So what kinds of things regarding your ability to be conscious and alert and awake and interactive? Is physical activity important to you? Are there certain activities that give your life meaning, that you love, that you would not want to continue on without being able to do? So it's not just thinking activities, it's also physical activities. Think about them with a broad stroke and start to frame what your life preferences would be. And these are the kinds of things we are going to look for within an advance directive document. They require interpretation. Advance directive documents are legally binding, but I will tell you that they are very difficult to apply in specificity without the focus of a healthcare agent. That is their job in a crisis. They are the person we will look to bring your advance directive preferences into focus. And together, the two things really will help. But primarily, it's that healthcare agent, that person who really has your goals and your values in the center of the discussion, and who can really tell us what you would say for yourself. As an illness progresses throughout a life, a chronic illness or a degenerative illness progresses, we start to get more specific about disease-specific planning. For example, excuse me, for someone with heart disease or heart failure, there is a certain path that generally follows. And so as you follow that path along, we can begin to be more specific about the choices that are before you in present tense, and also start to think about what that looks like for the future. As you are experiencing some limitations from that progressive disease, we might be able to talk about what's been hard about it. How have you adapted to this limitation? And is there a bright line in the sand for you? Have you reached a point where you're saying, I don't want to have any more limitations, and if I encounter them, is this the point where I would want to say stop? If you get to that point, then it's time to discuss the next thing, which is a DNR or COLST form, medical order. This is not an advance directive. This is a medical order, must be completed by your physician, and These are this is a medical order that will say do not do or you must do in terms of acting immediately should you encounter a health crisis. Again, we will discuss more about the form as we go further into this conversation. And we can clarify questions about that if you'd like to put those into the Q&A or the chat form, and we'd be glad to answer questions. Once you get towards the end of life and you are really making some very finite decisions about the kind of care and treatment you wish to have as your life is coming to an end or your time is short, we're moving down towards that end of life decision-making model where we're really focusing in on what is important for you to be able to do right now and how can we focus your care and treatment to provide for your comfort. And that usually involves, or often involves, adjunct specialists such as our palliative care folks and palliative medicines and treatments. These are medicines and treatments that are focused on providing for your comfort. They are not about modifying your disease any longer. They are not about restoring your health. It's really about helping you to live as long as possible with as few discomforts as possible and maximizing what time you have. Are there any questions about that? I'm glad to respond to anything that gets typed into the communications box.
All right, we probably can move on to the next slide.
Yeah.
All right. So as Sally just talked about, I'm getting an echo. I'm not sure. Sally, are you muted?
No. Yes. No.
Okay, I think that might have been it. So as Sally talked about this continuum of advanced care planning, I think that's really so important to think about this as a process that is ongoing. I think so many times we think about this as, oh, I check it off the list. Once I've done it, I don't have to think about it again. And I think one of the things we want people to walk away from this knowing is that we want you to continue to look at these documents. They used to be called living wills, I think, for a reason, right? Because we wanted people to continue to revisit them and to think about the documents as changing as our own goals and values change, as our perspective changes, as our priorities change. So as we think about advanced care planning and we think about our conversations with people who are important to us, we want to think that we want to continue to revisit our decisions and make sure they're still in line as our disease progresses. And I think as that previous slide showed, as we age, oftentimes our opinions change. Things that are most important to us when we're 18 or 20 may not be as important, and other things may become more important as we're in our 40s, 50s, 60s, and 80s. So as those changes happen, we want the documents to reflect that same progression. So some of the tools that we have available in Vermont to allow for that documentation to proceed as your thinking is evolving is we have different forms. And sometimes I think having a lot of forms can make people confused and not sure which one they're supposed to use. So we've got several that we wanted to just touch base on so that people would have, I think, a little bit better sense of how to approach this and to select the form that's right for them. I've often heard of this called as sort of like the Goldilocks phenomenon, right? As we're thinking about advanced care planning, we're not sure where to start and, oh, that form is too complicated and too big, I can't do it, that's not for me. Or that form doesn't feel right either, that's not for me. And so people tend to put it off. So one of the things we've tried to do is to create different forms that can help you identify things you're willing and ready to talk about now, and then know that you can come back and update as circumstances change. So as Sally stressed quite a bit already is this naming of a healthcare agent. We have a special form for that. All the forms can be found on the Vermont Ethics Network website if you need to look for them there. It's called Appointment of a Healthcare Agent form, just to be clear. And it's very simple. It's a 2-page document. It allows you to select the person or people who know you best and who you think can really be your advocate, when and if the need comes where you're not able to speak for yourself. And keep in mind, we're not looking to these people to have them answer questions and make decisions for you until you're not able to do so for yourself. So it's really important to know that by completing a document, you're not giving up any power to make your own healthcare decisions. The standard is always that you get to make your own decisions. And we're only looking at these documents and looking to other people when we can't talk with you directly to get the information that we need to make sure we can put the right plan of care in place for you. So this allows you to pick one person. You can name co-agents, which would have equal power. You can also name an agent and an alternate. So you could set up like your own hierarchy, say, okay, I want you to talk to this person first. If they're not able to be reached, here's the next person on the list. It's really up to you to think through the people that know you best and how best you want to set it up. There's no wrong answer. It's just what's right and for you. And it may not be what's right for someone else, but as long as it works for you, that's the best decision. The only caution I think I would give when naming agents, especially if you're going to select co-agents, so people that have equal power, is to make sure that they are on the same page in terms of what the decisions should be and how to navigate those in the moment decisions so they can work together as a team. Mm-hmm. Because what we want to try to avoid, if at all possible, is when we're looking to someone who's not you as the decision maker, we want to make sure that we're getting consistent information. So if you've got one agent saying, no, don't do these things, and the other agent saying, yes, you should do these things, that leaves us with a little bit of a conundrum. Now we've got to sort out what to do because the agents aren't together in the same plan. So that would be the only caution. It doesn't mean you shouldn't have co-agents. I've seen it work beautifully in some families, and in other families, it doesn't work at all because people don't work well together. So you kind of need to think about who your people are and who are the best people to represent you. I also want to stress that sometimes naming the agent is not your family member. A lot of people select someone who is not their immediate family member, and they do that so that they can allow that family member to just be the sister or be the spouse and not have to be in the position of being this strong advocate, and they can just be present for you at the bedside while letting someone else shoulder the burden of decision making. And that's fine too. So it's really about selecting the people, the person that is in the best position to be your advocate, who's not afraid to speak up to the healthcare team and say, hey, listen, we need to talk about what the plan is, or I'm not so sure that's the best choice for my friend or my family member right now. I need more information before I can make that decision. So that's sort of where we are in terms of naming of a healthcare agent. Really important. Keep in mind, though, if you don't have anyone you trust or anyone that you can name, it doesn't mean you can't do advanced care planning or complete documents. That's why we have both the short form and the long form advanced directive. These documents also allow for you to name a healthcare agent, but in addition to that, they allow you to put down some of the important things that you want people to know so that they can take the best care of you possible. So we want to make sure that we know what are the things that matter most to you. What makes a good day for you? Are there things in your life that you absolutely are unwilling to give up? Are there some sacrifices you're willing to make as long as it means you have more time? These are all really personal decisions. And again, there's no right or wrong answer. It's really about what is best for you. And the only way we can know that about you and provide the most person-centered care is if we have a lens into seeing what's important to you through either the document or your healthcare agent, or preferably both. But if you couldn't name an agent, you can always leave. You wouldn't select the naming of a healthcare agent form. You would skip to the next form, either the short or the long form, and I can tell you a little bit about the difference between those. And then you would draw a line through the section on naming of an agent, and you would only complete the other parts of the form that allow you to give more specific information about what's important to you. Because even though in Vermont, we are obligated to listen to and follow the instructions of a healthcare agent, we're also obligated to look at the written expressions that you've made about what's important to you and then to do our best to try to honor those expressions. Sometimes we can't because there isn't, what you're asking for isn't possible. Or sometimes we see documents that have contradictory information, saying things like, yes, I want to be on a ventilator, but no, I never want to go to the hospital. Well, we can't do both of those things. If you want to be on a ventilator, then you're going to have to go to the hospital. So sometimes we see documents that don't allow us to follow them exactly for some reason, but it doesn't mean we're not looking at them. It just means we're looking at them and then we're looking for more guidance if we see a contradiction to say what would make the most sense for this person right now today based on what we know is happening now. And it could mean that we change course once we find out new information after we get more information. So you can always complete an advance directive whether or not you have an agent that you can name. You can always give information about what your values are, what your priorities are, things that you would or wouldn't find acceptable. And that is what the healthcare team will use to guide the care plan, to do the very best that they can to align what the treatment options are for you with what you have indicated is most important. The difference between a long and a short form is really pages, to be the most simplistic about it. The short form, it's not super short, but it's five parts, about 5.5 pages long. And it really just hits on the high notes, the things that most people want to talk about: naming of an agent, what's most important to them, maybe give some specific information about some of those treatments that Sally was talking about previously, like feeding tubes and ventilators and the use of CPR should your heart stop, those kinds of preferences. Sometimes people want to give really specific instructions about, and so that part is there for you as well. And then the last 2 parts are, the part 4 is really about, funeral and burial arrangements, if you want to make those expressions known, and also about organ donation. Now, again, these are forms that are there to guide you in terms of information, but you are not obligated to fill in every box or check every question. You can complete the parts that work for you. You can draw a line through sections that you don't want to complete. And there are even places where you can just write personal statements or even make a reference to an attached personal statement. So we really see, I think advanced care planning really does need to be customized to the individual. And so you should feel free when completing forms to make them work for you. Some people like checkboxes. Some people would really rather just write out what their values are and use more of a narrative format to communicate their information. And either is fine. You should do what works best for you. And then, of course, have conversations with the people that you trust the most and who are most likely to be there at the bedside, worrying and caring about you and working with your healthcare team to see what the best plan of care is moving forward. So conversations are really, really important, and there's no substitute for that kind of communication. But having things written down is also really helpful because it gives people something to look back to and to say, oh, Mom said, look, she wrote right here what was really important, and it kind of keeps everybody focused on what you've already indicated is your priority or are your priorities. The long form is really quite long. It's 23 pages. But it has a lot of really detailed information and questions. I think if you are somebody that has had an experience with psychiatric illness or some mental health considerations, or you're worried about maybe the potential for a guardian to be might be needed given whatever's happening with your health, there are places on that longer form for you to give much more specific information about some of those considerations. And I think for the right person, it's really a helpful document. I think for many people, it feels a little bit daunting because there's a lot of pages, but I also know plenty of people who really like that kind of specificity, and it really speaks to their needs. So you can look at either form and pick the one that is the tool that works best for you. I just want to touch briefly on COLST orders, and because Sally already mentioned them, and I think our next slide has a little bit more to distinguish between the two, but these are quite different from the advanced directives that we talked about. These are actually medical orders, and so you really can't complete your own COLST order. What you need is to have a conversation with your healthcare provider, meaning your physician, nurse practitioner, or physician's assistant, whoever it is that you see, to discuss in quite detail what the various treatments are and whether or not those treatments make sense for you. DNR COLST orders are generally something that we think about when we are worried that a person might die in the next year. So someone who has advanced disease or has serious illness, and we're thinking, we're not sure, this person we wouldn't be surprised actually if this person died in the next year, given either their level of frailty, their age, their level of disease progression. And so this is where we want to make sure we have important conversations about some of the more aggressive medical interventions that we have at our disposal to keep people alive longer and to make sure that that is consistent with someone's desires. So this is a different kind of conversation. It does require that discussion with your physician, where you don't need to do that necessarily for advanced directives. Advanced directives are often conversations with family around the kitchen table. We just finished our Thanksgiving holiday, and there's plenty of people that say there's no turkey until we have the talk. There's plenty of people that used to do that over their Thanksgiving holiday. It was their time to check in with their loved ones and make sure everybody was clear on what the plan was. DNR orders are different because we really do need the expertise of those medical professionals to have them really put in perspective our options based on what's happening with our health. And I think we need to marry those two things in kind of a shared decision-making discussion. And then the Vermont Advanced Directive Registry is really just that. It's a place where you can send your advanced directive documents. They scan them into the registry. It's a free service for Vermont residents, and it allows those documents to be accessed by healthcare providers and hospitals across the state. It also is something that can be accessed because it's web-based. If you're traveling out of state, people will have access to your documents by using the wallet ID card that you're given. And we can talk a little bit more about advanced directives at the very end of the session. But I do want to progress to the next slide just so we can kind of put a box around the differences between DNR orders and advanced directives, so everyone feels really clear about those two different tools that we have available. And then we can segue for the remainder of our discussion this evening around disease-specific kinds of considerations, because I'm sure that's at the forefront of many people's minds. But just to summarize, when we think about advanced directives, naming of an agent or filling out the short or long form advanced directive or a different document that you find that works better for you, what we're really talking about is a preference-based document. Something where a person sits down, a person who has the ability to make decisions for themselves. So these are only people who are over the age of 18, not somebody who's already got a medical guardian. So these are people that are serving as their own decision makers. And they're contemplating a future where the chance may arise or where they can't speak for themselves. And if that were to happen, what do people need to know to take the best care of you? So as Sally, I think, discussed really early on, these are typically quite nuanced documents. Often we see a lot of if-then kinds of framing of situations. If it looks like this, well, then I would want that. But if it looks like this, well, then I wouldn't want that. So these are decisions that take a little time to sort of suss out. And so that having that healthcare agent to provide the lens and the context and maybe even some interpretation is really useful to help guide decisions. And again, once a person loses the ability to make decisions for themselves, they're not able to complete a new document. So you can only do this at a time when you have the capacity to make decisions. The other, the COLST orders, which as we said are quite different, those actually are medical orders. And as we talked about, it's sort of the outcome of this shared decision-making conversation with your clinician, your physician, your nurse practitioner, PA, and you coming together to come up with a decision. One interesting thing about COLST orders that I didn't mention before is that people other than the individual themselves can complete these orders, which means that your healthcare agent, the person that you name, may be in the position of having to give consent for a COLST order if the circumstances are such that you can't make decisions for yourself, and the clinicians are worried that you might die in the next year and they want to get some appropriate treatment plan orders in place. So this is where the advanced directive comes into play in helping to give that healthcare agent some insight that they can then use in conversations with the healthcare provider to maybe complete these COLST orders. It really just depends on the situation. But again, it's a medical order completed by a clinician in consultation with the patient. And this is more, instead of being a future-oriented document, this is more of a current document. It's going to guide the current treatment plan. Whatever happens today, this is what we're looking at. I think it's also important to recognize that these documents, the difference is that advanced directives are not looked at by first responders. So that 911 person that shows up at the house after the call is made is not looking for an advanced directive. What they are looking for is a DNR order, because that's what they're going to follow, a medical order in the event of an emergency. So if you were to have one of these orders, and just to be clear, I don't know if we said this at the beginning, DNR stands for do not resuscitate, and that has to do with the chest compressions if someone's heart were to stop. And COLST stands for Clinician Order for Life-Sustaining Treatment. So that's what that acronym stands for. But this is what the first responders and EMS are looking for to know whether they should or shouldn't start resuscitation if they're in someone's home. So typically people who have these documents tend to put them on the refrigerator so that they're readily available should a first responder show up at the house, and first responders do look. So I want to just close there. Oh, Sally's got her hand up.
I do. I just wanted to also offer to you folks that if you don't have an advanced directive or a COLST form, by default, what we do, most people don't have DNR orders, and unfortunately, most people don't have advanced directives. But what we do by default is that we will provide you with all the appropriate healthcare treatments and cares in response to any sort of emergency or urgency that you encounter. By not having one of these documents, it doesn't mean that you're limiting the kinds of access or care or treatment that's out there. You will get it by default. Our charge at the hospital as clinicians is to do things to sustain you, to work towards your restoration of health. That's the charge that we've been given. And so we will do those things. We hope you can help us with these documents, but certainly if you don't have them, it doesn't mean that we're not going to do things. It just means that we're going to hope to learn more about you if you have these documents and be able to be more specific, especially if you're living with a chronic or progressive illness where you've started to think about limitations. Those things help us do better for you. So please don't feel that if you don't have a document, you won't get what you want, because by default, you're going to get it all. That's we train and train and train to do things and to get you back home and get you back to your health and get you back to your life. That's our goal at a hospital and of all the clinicians that work there. But we really love to have your help and your guidance. It's important. We want to do things for you, not to you. Yeah. And so this is what helps us.
This is probably a good segue to the next slide. Christine, if you want to progress to that one. Because I think we're probably at a point where we can really talk a little bit about how do we think through our decisions when we're worried about particular things like COVID or dementia or something else. Like, what are some ways in which we can craft good advanced care planning documents that take into account maybe some disease-specific considerations that are on our minds? And so I'll let Sally start going through some of these questions and things you might think about as you think about COVID, and I think any illness, and Sally can talk a little bit more about how maybe COVID has been the thing that's brought you to thinking about doing advanced care planning. But when it comes to the decisions, sometimes being too specific about the disease, it gets in our way of making a good plan. And so I'll let her take it from here.
Yes, so this slide, I love this slide a lot because this slide really puts forth a really great frame around the conversations that we have at the bedside with patients, but also with their surrogates. So it's really about establishing where a patient was at prior to whatever brought them to the hospital, and then looking from that point forward to understand what was important to that patient. I said earlier that we could really get into the weeds if we wanted to about nitpicking through details about ventilators and feeding tubes and whatever, but that's pretty unproductive, I think, in terms of our time here tonight, but even time when you're ill in the hospital. It's really important for us to know who you are, know what's important to you. What are the things that are important for you to do, that what makes your life good? What are the activities? What are the engagements that are meaningful to you, that give you that meaningful life? And if I can get you there and I can see a path forward for you to get there, I can restore you there, I'm going to put every tool I have on the table for use. Unless you tell me you would never want to go there. But when people write that into an advance directive and send any sort of very specific form, like lots of times people will say, I never want a ventilator, never ever want a ventilator. However, they might have a pneumonia, and a week on a ventilator may be all it's needed to turn somebody around, especially if they don't have disease in their lungs. And we really just need the ventilator to bridge the person somewhere. So while it's important for me to know that you wouldn't want to have a permanent ventilator, would a temporary ventilator be something you would be willing to encounter or engage with? Some people say, I never, ever, ever want to live in a nursing home or where I cannot take care of myself, feed myself, toilet myself, bathe myself. And yet there's a lot of people who have an injury or an illness that renders that difficult or maybe even impossible for a short time, and a nursing home stay for a short time to get rehab and restoration would be something they might be willing to encounter. These are the kinds of things that you should discuss with your healthcare agent, and why a very finite statement in an advance directive may not really be totally specific to who you are or what your goals and preferences are. It requires some conversation. And really, it's about coming to learn who you are and what is important to you. But some people have some very specific limits, such as cognitive function, and often we see this in terms of the dementia population. If they can no longer recognize their families, if they can no longer engage in conversation, or they're not able to take care of themselves, we often see that in that population, sometimes that people start to draw the line there when they've lost that cognitive ability, that thinking function of their brain, and that they start to say that that's when I would want to place some of those limitations. And perhaps that might be the time to start talking with the clinician about a COLST order, from an advance directive moving to a COLST order. Physical functioning a lot of times is important for people where if they're unable to move for themselves, take care of themselves, if they're able to walk and they become bedridden. I had one patient one time who had said to me, he was a dementia patient and he lost his driver's license. And to him, this was the beginning of the fast downhill slide. And he said, I've lost my ability to drive. I'm no longer a contributing member of my community. I've lost the ability to be independent. I'm now dependent on others for my basic things like going to the grocery store or the pharmacy. And that's where I draw the line. That was his line. And that's okay, because it's his determination. This is part of being a self-determining, self-governing individual. You get to say what's important for you. You get to say no. even when you've lost the capacity to do so, this is the way that you are able to set that out while you still do have that capacity. And we are bound to respect that. It is our responsibility and duty to respect that. Whether you can tell us or you can put it forth in a document and have your healthcare agent deliver the emphasis to it. It's important that while you're able to fill out a form or complete the delegation of a healthcare agent, that's what saves that place for you to be independently determining what you will or will not endure for your healthcare. We can do a lot to keep a body going, but what is important is that we do what you value. And this is an important thing that we listen to. Some folks, when their time gets short, they don't want to medicalize death. They don't want to come back to the hospital for more fluids and antibiotics and more treatments. Sometimes they don't want to come back to the hospital. And this is a way you can establish that. You may say, if I can never live in my house, if I have to live somewhere else, that's my line in the sand. Or if I'm unable to move for myself, I can't take care of myself and bathe myself, and I want to be taken care of by others. And if I reach that point, I want to start to put some limits on. So there are certain situations that folks might be able to speak to that will help us. But I think what is important to know is that while you may be sitting at home completing your form thinking that this is going to be, my weakness is my renal function, my renal failure, and I'm anticipating a dialysis problem at the end of my life, you may end up showing up at the hospital with a stroke or a heart attack. And so having some of these goals and values that you describe within your advanced directive be more broad spectrum and really more about what your priorities are, what's important to you, that's an important thing to think about, not just your renal disease, but think about really who you are as a person, and have that. Yes, go Cindy. Are you muted?
I was. I just wanted to chime in and say I'm seeing that we have about 9 minutes left. And as Sally was saying, we titled this presentation "No Crystal Ball," and the reason we did so is because it's very difficult to predict the circumstance or situation that we will find ourselves in. Even with COVID sort of looming out there, we can have a very, very great document that's specific to COVID that says exactly what to do when or if your respirations become so difficult that you might need a ventilator. And then you could still fall on the ice this winter and break your hip or hit your head. Yeah. And it may not be, and having just a very disease-centric focused advanced directive that's really around like what's happening right now, while helpful if that's what happens, doesn't help give us as much insight into what we might need to know if you do slip and fall on the ice and hit your head and fracture your hip. And all we know is that in the event of COVID, you definitely do or do not want to be put on a ventilator. So still, I think as much as I think there's a desire to be specific in light of the recent times, I would encourage you all to think beyond just COVID and to think about just these kinds of questions. What are you worried about in the future about when it comes to your health? What is really important for you to be able to do as any disease or illness or even, catastrophic injury happens? What are the things that you value? Are there anything that's unacceptable? I think sometimes it's hard to think about all the things that you like to be able to do, and it's much easier because it's a much shorter list for all the things that might be unacceptable. Some people have a very small list of what would be unacceptable and a very big list of things that are acceptable.
Cindy, I
think go ahead.
What you're talking about is that very last section, and you and I talked about this today. It's really about the trajectory, about what's happening to you in current times, and are you are you on the path to some restoration or recovery? What is the trajectory? And will we meet a meaningful goal for you? And that way, any one of our tools that we have in the toolbox will be brought forth to get you towards that meaningful goal to recovery. If not, if the trajectory is not to get you to a meaningful recovery that you've identified, then we might want to think about other kinds of things we can do to support you if your time's going to be short. And I think that's really what you're getting towards. It's like really identifying your preferences, your values, and matching up our treatments with your values. Doesn't matter what the treatment is, because if your goal is to get better, let us get you better. Don't tie our hands. Sometimes we see people write things on their documents like, well, I want to have CPR, but only one round. And it's like, but what if that second round you would survive and you'd be fine? Or I only want to be ventilated for 5 days, but what if you're recovering and your trajectory is on the path to recovery? And if you say only 5 days, but you really need, we think, another 48 hours and you really need 7, why would we stop? So it's really broader spectrum than that, if you will. Keep that in mind when you fill out your document. And if you have questions, call your primary care provider, call the hospital, call sort of your area agencies are available to you. There are folks, coaches that work with people to help you think about your documents and to help you complete your documents. Howard Mental Health folks will help you with your documents. There's all, yep, all sorts of people are out there that are very glad to help you. And if nothing else, I think, Christine, you in the library, you have some folks that will help at the Fry Memorial Library, at the medical center. I think there's folks at every hospital in Vermont that will help you. You get into contact with the right people, talk to your patient and family advocacy folks at the hospitals. They'll get you on the right path.
Let's move to the last slide. I'm looking, we have about 5 minutes left. I'm hoping that if people have questions, they're typing them. I'm seeing a few published ones, but I've been trying to follow the questions in the Q&A, and I'm not seeing anything specific yet that's come up.
There's one about you already addressed the one about
right.
Co-agents, pros and cons to having more than one. You addressed that because if you have people that disagree, you're kind of stuck. Here's a great question. Is it true once one is on life-sustaining equipment, it will not be removed no matter what? No. What's true at breakfast is what's true at breakfast is not always true at lunch or dinner. And if there comes a point where a person would not want life-sustaining treatment, a ventilator, a feeding tube, it is perfectly ethically permissible to change your mind. And with the exception of New York patients, you must, for feeding tubes, you must have endorsed a healthcare agent specifically with the authority to cancel a feeding tube or discontinue a feeding tube. That is a New York specific law, but in Vermont, that does not exist. In Vermont, you can have the surrogate make that decision.
Yep, and there's no ethical difference between starting something or, not starting something or stopping something once it's no longer achieving the goal that you've identified as important. So I think it's really important to keep that in mind, that once you start down a path, if that path is not heading in a direction that is acceptable, and we don't know that unless we've done a trial course, and I'm a big fan of trial courses of treatment, which is to see if it's going to get us where we're hoping to go. And if it's not, we absolutely can shift the direction to be appropriate for what you've identified as important. So I think I think that speaks to that question exactly. So just in the last 2 minutes, I just want to make sure people know what to do once they've completed a document. If that's where you end up, you should make copies or have someone help you make copies. Keep the original for yourself. Make sure your healthcare agent, who presumably you asked to be your healthcare agent before you name them, but make sure that they have a copy. And copies have been given to any relevant friends or family who you think would be helpful for them to know your wishes, as well as your doctor and the hospital. And then the Vermont Advanced Directive Registry, I would strongly encourage your support there. We've got over 40,000 Vermonters who've put their documents in the registry these days. It's available, it's an online database, as I mentioned previously, and every year you'll get a reminder from the registry asking you if you have any changes to make, which I think really supports kind of what we said at the very outset, which is that this is a process and a continuum, and you should be revisiting these documents. So one of the sort of positive benefits, not only of access, being able to access these documents readily when they're most needed, is that we'll also, you'll get a reminder to revisit your document periodically and make changes as needed. So I think, I'm not sure if there are any other questions.
There was a question, actually, I just typed a response to somebody about once you move to another state, do you need to complete a new directive? And I said what I said was not immediately. Generally, these documents are recognized across state lines, but because there are different rules in every state, once you're settled and you get established with a new healthcare team, I would recommend that you complete a new state-specific advance directive so that you're certain your wishes will be respected where you now live. These are documents that need to be living documents and revised throughout the course of your life to be current to your current goals and values. So this would be a good time to make a new one if you move to another state.
And the laws are slightly different from state to state, so it's always worth, once you're settled and established, just double checking and making sure that you've got a document. Typically, we recommend people use the form that's in alignment with the state in which they reside. But as Sally said, there's very good reciprocity between states. And so it's not an urgent need. But if you're once you're settled and established and you've met with your doctor, it's worth looking at that state form just to make sure everything's in alignment. Any other burning questions that people were hoping to get answered?
Burning questions about advanced directives. It seems like a big daunting thing, but dive in. It's not as bad. And when you get it all finished, it's really quite liberating. This is about making sure you're going to be taken care of the way you want if you can't speak for yourself.
And it's truly,
like I said, we're going to do everything. And that could be good, or maybe it's not.
Or not. It's truly a gift to your family. Yeah, I think it's really, I mean, these decisions are never easy for the loved ones who are making them. But I will say that I've never met a person who said it was made harder because we had conversations and there was good planning documents. Everyone I've encountered in my 13 years at the Ethics Network has said these decisions were never easy, but I feel I had great comfort in knowing I wasn't left wondering if I did the right thing. I felt confident, even though it was hard, that I was doing what they had wanted to have done. And so I wasn't making the decision, actually. They'd already made it. I was just serving as the voice when they couldn't speak for themselves. And I think that gives people a lot of comfort when sometimes these decisions can be really difficult and we're not sure what to do. So I applaud you all for taking the time out of your Tuesday evening to join Sally and I and participate in this discussion about a really important topic. And I hope it inspires you to go home and have conversations and hopefully complete a document of your own.
Yes.
Christine, do you have any closing comments for the attendees?
I do. Thank you so much, Sally and Cindy, for that great information and discussion. So that concludes this evening's presentation. Just a reminder, you will get an email in a couple of days that will have a link to the survey, the recording, and then most important, all of these great resources that Sally and Cindy have been telling us about. So you'll get a PDF of the slides and some other resources mentioned in the presentation tonight. Also, I can also, if you don't have access to a printer and you want your own copy of, an advanced directive, I would be happy to mail those to you. So when we can communicate via email, just let me know and I can send that to you in the mail for free. So I think that's all we've got, and on behalf of UVM Health Network, I'd like to thank you for watching tonight's offering, and we'll hope you will join us for another presentation, and we hope you have a wonderful evening. Good night.
Thank you, everybody.
Thanks, everyone. Christine, can we stay on for a minute?